We have to compare it with the existing tool in the literature, but I tried to come up with a very simpler and clinically relevant concept. Let's see what it is. So we see the results after shoulder rebalancing is with a congruent glenohumeral joint or quarters 1, 2, and 3. The results are fairly predictable. And most of the children, they get good range of external rotation and abduction. As you can see in this boy, a 12 years old boy, with persistent internal rotation, and the point of elbow is facing out, which is a common concern. And the second thing is what's known as trumpeting, while a child is trying to do hand to nose or hand to mouth, which abducts the limb. And with a conventional surgery, you can see that the arm posture improves substantially and the trumpeting is also gone. But are the results same for all the patients? Let's see one other patient of the similar age and similar glenohumeral dysplasia underwent similar procedure. So this is the girl who presented. The father was concerned that when she holds something, she points the left elbow outward, and that's the concern in the society. People ask, what's wrong with your child? And when it comes to lifting the arm, she doesn't use this because she cannot do abduction from this. She has to use this hand, and her resting position is very conspicuously alarming. And so we perform the same surgery on this girl, which we performed on the last case. And let's see what was the result. The results were great. As you can see, external rotation was full. She could reach behind, which she was not able to do before. She had also full range of abduction, which she didn't have. And she could also reach behind the occiput, which is a very behind the spine, which is very important for a young girl to fix up their undergarments. The parents were still not happy because she had still pointing arm. Her resting position was still in internal rotation. Although she could do all the overhead activities, she could do full range of external rotation, she could do full range of abduction, but still this point has not gone completely. So what is the difference between these two patients? That was the concern. And we thought that what can be the proposed etiology of what we are calling as persistent arm internal rotation posture or AIR posture. So proposed etiology can be there can be a residual internal rotation contracture or tightness of some soft tissue which is preventing the arm to sit nicely in adduction and external rotation. The second thing can be determined inadequate remodeling of glenohumeral joint. If we perform these surgeries into Waters 4 or bad type 3s, and then there is not adequate remodeling, and so they are keeping the arm internally rotated. And one more etiology which can lead to this is there can be internal rotation arising from the humerus. As we all know that just like in cerebral palsy, there is persistent of anteversion of femur, but not all the anteversion is coming from the femoral head. If you check at every level, and there are 3D studies of the whole femur, which shows that there is the accumulating rotation in the femur, which is leading to anteversion. Similarly, this can also happen in the children because the internal rotators, they don't insert on the humeral head always. Part of subscapularis, pectoralis major, other internal rotators, they insert below the head, and that posture can give rise to what's we term it as a humeral internal rotation. So, to understand this in a better context, we started taking concomitant elbow axial imaging along with the typical shoulder axial imaging to identify what is the level of glenohumeral dysplasia and whether there is any associated humeral internal rotation in this patient. So what we studied, so all these patients were considered for MRI. We use 1.5 Tesla MRI machine, which is easily available everywhere. And we got the cartilage sequences, or what's termed as three-dimensional axial gradient echo images. General anesthesia was used for children who were less than 7 years old. Child is placed in the whole body coil, and we did not change the child's position, and patients were not moved in the gantry to preserve the coordinate system of humerus. Because if you change, then there is a chance of mistake in the measurement or change in the measurements. Arms were kept against the side of the body and as anatomical as possible. Separate, once these sequences are done, all the axial images right from humerus or shoulder to elbow was done. A separate imaging of shoulder with dedicated shoulder coil was taken, so that those two images of shoulder, which might be at a different level, can be brought together at the proper anatomic level. I'll bring what is a neutral or central anatomic level is. And then ideal axial image of shoulder and elbow were superimposed with software. So what is ideal axial shoulder image, or what we name it as a subcoracoid image? So if you scroll through the shoulder images, the first one is, this is the coracoid beginning, where this is a bony coracoid, this is cartilaginous, and this is the acromion process. If you start going down with 1 millimeter cuts, you will see the acromion is still cartilaginous. A part of it is cartilaginous, now it is bony. You go further down, and then a point would come where the coracoid would start disappearing, where you see the coracoid minimum, and beyond which point the muscle would start. That's known as disappearing coracoid or a subcoracoid image, and that is the central humeral shoulder image, where you can take the glenohumeral referral image. So this is the ideal axial image of shoulder joint. And then we have to go for the ideal axial elbow image. That axis is known as transepicondylar axis. So if you see the distal 1/3 of humerus, it will start like this. So there is a shaft of humerus which is starting to enter into the olecranon. There's a beginning of olecranon fossa. You go further, there's a center of the olecranon fossa where the bone is very thin out, and the next curve you will see there's flaring up of the bone. And this is the axis, this is the point where you have to take, there is a cartilaginous lateral epicondyle and there is a bony epicondyle. These 2 points are made in the most convex part of this, and you draw a line, and that line is termed as a transepicondylar axis. If you go further below, you will see that the lateral epicondyle is disappearing, so this is not an ideal image. One image prior to this is the central image. So we have to teach our radiologists to identify which is this ideal image. And then comes the superimposing of these images. So with the software, they can superimpose the image like this. So first you have to draw the mid-scapular axis, which we draw in a typical Waters classification. So on your right side is an affected, and on the left side is a non-affected side. Then you draw a transepicondylar axis. This is known as mid-scapular line, and this is the transepicondylar axis. And the angle between these two lines, it is termed as arm internal rotation angle, or AIR angle, which is typically 20 degree. But now what happens that here the apex is here, and the transscapular line or mid-scapular line is in front. If you draw an angle between these two lines, you will see the angle going out of the console. So you have to shift this transepicondylar line this way, and the angle between these two will be calculated in minus degrees, right? So this is plus 20 and this is minus 25, and so the difference between these two is arm internal rotation angle difference, which is 45 degrees. So this means that the difference between the humeral internal rotation compared to normal side on the affected side is about 45 degrees. What we have seen further, that when we bring it to the clinical aspect, you see the arm is in interrotation posture. To see what is the exact degree of rotation, you have to ask the child to flex the elbow. And when they flex the elbow like this, you will see this angle. Then you have to draw a line parallel to the arm axis, and then draw a line on the radial side of the forearm, and this angle difference, which is about 15 degree on this side and 60 degree on this side, would correlate with your MRI imaging findings, which was the same as 45 degrees on MRI. It will be the same on 60 degree on this. Now the question would come to your mind then, why we just don't use the clinical epicondylar palpation? But then there are differences in the shoulder, so I will come to that. So this is angle we have now entered into our clinical examination. We mentioned it as an arm internal rotation angle and what is the difference between the two sides. So final image should come like this. So there are, till now we had only 3 images. One which is without any measurement, the second with what is the percentage of humeral head anterior to the mid-scapular line, the third was glenoid retroversion, but now we have one image with superimposition which will give you the radiological arm internal rotation angle difference. What are the clinical implication of AIR angle? I'll take you back to the case which we saw before. So this girl who presented to me with this kind of deformity, and on pre-treatment CT scan, as she was 10 years old, so we did a CT scan and you can see the retroversion was 6 degree on the non-affected side and it was 32 degrees on the affected side, and there was mild subluxation here, and so this was Waters type 3. So we thought that we can do minimally invasive subscap release with tendon transfer, or MISR plus tendon transfer, as it is a congruent glenohumeral joint, and we could change her from here to here. So this angle has gone, but she's still in internal rotation posture. Now we got a 6-month follow-up MRI after MISR and TT, and you can see that we could change from Waters 3 to Waters 2 now, because the glenoid retroversion difference is about 6 degrees when you compare this, and about 40% of humeral head is in front of the mid-scapular. So we could make the difference in this child, but that difference is seen only on the clinical movement, but when at resting posture, there is no significant difference. So why this happened? So what we did now an axial elbow imaging along with this. So what shows, you can see this is the normal side, this epicondylar axis. Now the arm interrotation angle is 25 degrees on the non-affected side, while it is minus 40 degrees on the affected side. And so the arm interrotation angle difference is 65 degrees. So that shows that although there is only 6 to 10 degrees of retroversion difference in glenoid, the arm internal rotation is more. So if we deduct the glenoid retroversion, that is 10 degrees from the 65, so our child is having around 55 degrees of internal rotation, probably coming from humerus. So what we started doing, we checked the full range of glenohumeral motion in these patients. These patients typically have a good range of internal rotation, so that this child could reach easily and we could gain a bit more of internal rotation. And so we did a derotation humeral osteotomy as a secondary procedure, because it's a cosmetic deformity, not a functional deformity. To bring her position into more functional and cosmetically acceptable position, we did the derotation osteotomy. And what amount of derotation we did is the amount which she had in excess, that we turned that 30 degree outward. If we have done more than that, then she would again have a midline limitation. So we did around 30 degree of rotation, and this is her final outcome. So you can see this scar of interrotation osteotomy. Now we can see the elbow crease in the front, which was going inside. You can see that gradually the distance between the waist and arm is reducing. It is just 2 months follow-up. So with more follow-up and more strengthening, I'm sure she would come a bit more nearer and her posture would also improve. So this kind of change we could make in this girl. If I would have told parents from day one that she would need only one surgery, then parents would be dissatisfied with me. But now, based on this radiological finding, at the outset we explain to parents that your child may need a secondary derotation osteotomy. And we did not do an excess of derotation because she can still reach to her spine to back to spine and to spine. Similar example, I'm reinforcing this concept. This patient was operated the same way because he had Waters, early Waters 4, and at the age of 7, I thought that I'll do a minimally invasive anterior release and tendon transfer, and he gained the full range of external rotation, full range of abduction. I thought parents would be extremely happy, but they are not, because the child is still having arm internally rotated and the elbow is pointing outwards. So we checked the arm internal rotation angle, as you can see from the top, and if you draw the lines, the difference was striking difference of around 45 degrees. And so we saw the axial images. So this were the axial image before the surgery in 2014, and you can see it was a retroverted glenoid with subluxating humerus. So it was fitting into Waters type 3. With the retroversion angle was 32 degrees on the affected and 2 degrees on the non-affected side. And then after tendon transfer and soft tissue release in 2018, 4 years later, you can see that it is still, there is a bit of retroversion. It's about 12 degrees. But if you see the inclination of glenoid, which was quite retroverted, now it has changed to the front. So this patient has improved in external rotation abduction, but his resting posture is still internal. So why it has happened? So we did an axial imaging again, you can see, and you can see again here. So we have to overlap this two line, and arm internal rotation angle difference is around 40 degrees. If you now calculate this 40 degrees and the retroversion of glenoid around 20 degrees, this would correlate with the clinical difference of 60 degrees. And so this patient also required what's known as derotation osteotomy. Again, before doing derotation osteotomy, we have to check that this child is not having any internal rotation contracture. As you can see, passive external rotation is 70 degrees, and he has excess of internal rotation range. So if a patient is not having this range, we have to stabilize the scapula and increase the range, and then we have to do this procedure, and this child also underwent derotation. And the last implication of this procedure, this is a very young girl, 2 years old. I did Botox at the age of 1 year, but still she keeps the arm internally rotated. She has a bit of truncating, and we now started doing this imaging in this child, and you can see that she is late 3, and she is now beginning to get into a bit of false glenoid now, and this difference is around 50 degrees. So I have to explain parents that we will do, as your child is young, we will do the tendon transfer with soft tissue release, but there is a possibility that she may still keep the arm internally rotated, and then we may have to do a secondary derotation humeral osteotomy. So less age, that does not mean that this child will not need any procedure, and with this radiological finding, we can probably predict. We have not come to a conclusion that what degree of internal rotation can leave behind the visible internal rotation posture, but with a more number of patients will come to some conclusion after this. So in conclusion, 2 new terms we have coined it. But first is the clinical arm internal rotation angle, and the other is arm internal rotation angle on axial image. And we typically see that more the AIR angle difference, the patient may require secondary rotational derotation osteotomy, and we can explain the need of second surgery to parents at the outset, so that there is no conflict and disparity between parents and treating physician. Thank you very much. Yeah.